Chalo, let's begin. Welcome everyone. Today we are going to tackle a very important topic. I'm telling you, this is crucial not just for your exams, but for your future clinical practice. We're talking about antidiuretics. So get your notes ready. This is going to be a really good one.
So here's our game plan for today. Think of it like a roadmap. We'll start with the basics, the physiology, then we'll meet the drugs that mimic it. After that, we'll figure out where to use them, what to watch out for, and finally, we'll wrap up with some really high-level concepts. It's a complete package, everything you need to absolutely master this chapter.
All right, let's dive right in. First things first, we have to understand the main player of this whole story, vasopressin. Its entire action, everything it does, really just depends on which receptor it binds to. You can think of it like pressing a specific switch in the body.
So, this hormone vasopressin, you'll also see it called antidiuretic hormone, or ADH. It's a real multitasker. It's got two primary jobs in the body. And how does it do them? Well, it uses two completely different types of receptors. And let me tell you, understanding these two receptors, that is the absolute key to unlocking this entire topic.
Okay, look at this. This slide really simplifies everything, doesn't it? Just remember this one simple funda. V1 is for vasoconstriction. It's the vessel squeezer. It squeezes the blood vessels. V2, on the other hand, is in the kidneys, and it's the water saver. It's all about saving water. So V1 squeezes, V2 saves. Just burn that into your memory.
All right, so now that we know the switches, let's talk about the drugs themselves, the dawa we actually use in the clinic. Think of each drug as a specialized tool in our toolkit. Some are designed to press only the V1 switch, some press only the V2 switch, and some, well, they can press both.
Now this is very important for your exams beta. Make sure you mark this one. You can see here, lipressin and terlipressin, they both hit V1 and V2 receptors. And terlipressin is interesting. It's a prodrug, which means it gets activated inside the body, giving it a nice long action. But look at the real specialist here, desmopressin. It is a selective V2 agonist. And what does that mean? It means it's the perfect tool when all we want to do is save water without touching the blood pressure.
So you see where this is going, right? The really crucial part, the clinical art, is knowing which tool to pull out of the toolkit for which job. That's our game plan. We have to match the right drug to the right disease, and it all comes down to one question. Do we need to squeeze the vessels, or do we need to save water?
Okay, let's start with the water saver effect. Let's focus on the V2 action first. So what are the situations where we need this? Well, think about any condition where the patient's body is just losing way too much water. In that case, obviously, we need a drug that's going to talk directly to those V2 water saver receptors in the kidney.
And this is exactly why desmopressin is the absolute star player for these conditions. Think about it. Pituitary diabetes insipidus. What's the problem? There's no ADH. So what do? We give a V2 agonist. What about bedwetting in kids or nocturia? We want to reduce that nighttime urine volume, so we use a V2 agonist. It's even used in some bleeding disorders like hemophilia because it helps release clotting factors. And for all of these, which drug is our go-to? Desmopressin. It's the drug of choice.
Okay, now let's switch gears completely. Forget about saving water for a second. Let's talk about a totally different scenario. Here, the problem isn't water loss, it's bleeding. An emergency. We need to stop that bleeding, and fast. How? By squeezing the blood vessels. This is a job for the V1 vessel squeezer effect.
You see, in a life-threatening emergency, like bleeding esophageal varices, you absolutely need that powerful V1 vasoconstriction. And this is where terlipressin becomes our hero. It's the go-to drug. It squeezes those mesenteric vessels, which dramatically reduces blood flow to the area and gives a clot a chance to form. This action can be literally life-saving.
But listen, every powerful drug comes with its own set of risks, and these drugs are absolutely no different. You have to handle them with care. You must know exactly what adverse effects to look out for, because this is absolutely crucial for your patient's safety.
Okay, pay very close attention here. Let's start with the V2 side effects. If you overdo the water saving, you can get fluid retention. This dilutes the sodium in the blood, leading to a dangerous condition called hyponatremia. This can cause what we call water intoxication, leading to cerebral edema, and the patient can present with headache, confusion, even seizures. It's serious. Now, what about the V1 action? Well, if it squeezes the coronary arteries too much, it can cause angina or chest pain. This is exactly why desmopressin, being V2 selective, is generally considered a safer option. So a quick question for you. A patient is on vasopressin and they suddenly develop chest pain, angina. Which receptor is responsible for this? Think back to our funda. What causes angina? Constriction of the coronary vessels. And which receptor is our vessel squeezer? Of course, it has to be the V1 receptor. See? It's simple, as long as you remember the basics.
All right, we're almost at the end. Let's finish up with two very interesting, slightly more advanced concepts. These are the kind of things they love to ask about in exams to separate the good students from the great ones. First, we'll look at a paradox, a drug that does the opposite of what you'd expect. And then, we'll talk about a new class of drugs that are designed to block vasopressin.
Now this is a classic exam question, so please listen carefully. How is it possible that a diuretic, a drug that is supposed to make you urinate more, can be used to treat diabetes insipidus, a condition where you're already urinating too much? It sounds crazy, right? It's a paradox. But the funda is actually quite simple. Thiazides make you lose salt. The body senses this salt loss and goes into compensation mode. It starts reabsorbing a lot more salt and water much earlier in the kidney, in the proximal tubules. So by the time the fluid gets to the end, to the collecting ducts, there's much less of it left. The end result? Less urine output. A diuretic acting as an antidiuretic. It's very clever, isn't it?
And finally, let's meet the antagonist of our story, a drug called tolvapaptan. This one is a selective V2 receptor blocker. It does the exact opposite of ADH. So if desmopressin is our water saver, then tolvapaptan is the water releaser. It's an aquaretic. So when would we use this? Well, in conditions like SIADH, the syndrome of inappropriate ADH secretion, where the body is making too much ADH, holding on to way too much water, and the patient's sodium is dangerously low. That's when we bring in tolvapaptan to release all that excess water.
So, to bring everything full circle, here's a final thought for you. Imagine you have a patient with SIADH. Their sodium is dangerously low because their body has too much ADH action, and it's retaining way too much water. Looking at the tools we've discussed today, how would you approach this? Would you use the water saver or the water releaser to fix this problem? It's all about applying the funda. Think about it. All right, that's all for today. Keep learning.